time together this afternoon. So over to you. And yeah, so there's the program. So over to you.
Okay, so I'm going to share my screen. Okay, good afternoon, everybody. Sorry, my video is not working, so you are just going to hear my voice. So today, I'll be giving an overview. It's more of like a skinny dip rather than a deep dive into early transplant complications. And I chose to do it this way because when I started transplanting by just a few of us after JP, as Estelle has mentioned, JP Singh was actually the one that brought transplant to KZN, and he started teaching us and then had to leave. And so here I was left trying to gather myself and try to get this unit going again. So I decided to do not an in-depth pathophysiological sort of overview of transplant, but rather what actually happens on a day-to-day basis when you're managing patients with following allogeneic transplant, and then just focusing on a few of the more conditions that we struggle with. So as we all know, any recipient of a hematopoietic stem cell transplant, especially those undergoing allogeneic transplant, will be immunocompromised and may also have treatment-related organ and tissue damage. They therefore require careful monitoring in the early post-transplant period to ensure that complications are recognized early. And we therefore need medical and nursing staff to be aware of what to look out for. Over the years, but better clinical care and management of early post-transplant complications have led to significant lower rates of transplant-related mortality. However, this still is a problem. So for us to understand the complications associated with allogeneic transplant, we have to have an understanding of the entire transplant course. And so if you had to open up any textbook and read about the early complications of transplant, you often will find that they would discuss infections, acute graft versus host disease, vascular endothelial syndromes. This is what Linda will be covering, graft rejection. However, when you are actually managing patients on a day-to-day basis, you would find that there are other complications that actually arise in the other systems, and hence need to be vigilant with your patients. So I will actually be briefly covering the different systems, but we'll concentrate a little bit on the infections and hemorrhagic cystitis. So what are some of the factors that we need to understand before going in depth into any sort of complication? Is that there are many factors that are sort of interweaved into causing complications in transplant. So first of all, the type of transplant. So allogeneic versus autologous, you'll find that patients undergoing autologous transplants tend to have less of the immune-related problems, but are still at risk for infections mainly. As compared to allogeneic transplants, where it's more intricate and more complicated. So the type of stem cell that you're using, is it bone marrow, peripheral blood, or cord blood? The donor type, is it a sibling, matched sibling, an unrelated donor, matched related donor, or is it a haplo? The conditioning regimen as well can cause post-transplant complications. Interval post-transplant, how long after the transplant is the infection or whatever is going on that has happened. And then the type of GVHD prophylaxis that is used can also contribute to complications. Some of the drugs used for infectious prophylaxis may contribute, and most importantly, immunosuppression and the length of neutropenia. And another very important factor is the patient itself. The patient who may have had underlying comorbidities, or the type of treatment that he or she may have received prior to transplant, the type of disease that you are transplanting. So there's a lot to consider. So the conditioning regimen, so why do we need to condition a patient? It's to allow for engraftment. So the goals of conditioning is to suppress the recipient's immune system, particularly the T cells, to aim to prevent rejection of the graft. And then the other goal is to eliminate the tumor. So myeloablative regimens and those employing total body radiation, cytotoxic chemotherapies, example, busulfan, melphalan, result in profound, prolonged neutropenia, can cause mucositis and potential organ toxicities. So recipients are highly susceptible to early infection and sepsis in patients that have undergone myeloablative conditioning. However, less intense regimens are used in older patients, and these may result in minimal neutropenia and mucositis and a lower risk of infection. However, these recipients may also experience prolonged neutropenia should the graft fail. So then what about the graft? So the closeness of the HLA match dictates the likelihood and severity of graft versus host disease, as well as the intensity of immunosuppressive treatment that is used. And then, as I said before, the type of match or the degrees of match that might be used. So is it an HLA match sibling or twin? Is it a HLA match but unrelated, haploidentical, or partially matched? So what one would find is that the patients that have undergo a haploidentical transplant or partially matched transplant may require more intense immunosuppressive regimens to prevent GVHD. So the stem cell source also may impact infection, amongst other things. So the bone marrow, so patients undergoing actual bone marrow transplant have more prolonged periods of neutropenia and at a high risk of early infection. Whereas stem cell patients that receive peripheral stem cells are actually at a higher risk for GVHD. Cord blood is typically obtained from unrelated donors, confer a much lower stem cell dose than in other transplants, and these patients may experience delayed engraftment. Neutropenia may extend for longer than 6 weeks or longer, and at times T cell immune dysfunction may persist for much longer. So then with regards to the underlying host disease, so it is the type of condition for which you're transplanting your patient may also play a part in the complications. So infection risk is impacted by the disease for which the patient is being transplanted and the presence of preceding infections. For example, patients with acute leukemia, the disease itself predisposes to neutropenia and other defects of innate immunity. And profound neutropenia of more than 10 days duration is considered a strong risk factor for bacterial and invasive fungal infections. And then other factors that might increase risk for infection, especially invasive fungal infections, diseases like advanced or refractory AML, high-risk MDS, chronic neutropenia prior to chemotherapy, iron overload, secondary to repeated blood transfusions, and prior fungal infection. Anti-leukemic agents have been shown to diminish antibody response to primary antigens, thereby increasing susceptibility to bacterial pathogens, even in the absence of neutropenia. So if you transplant a patient with primary immunodeficiencies, so this may predispose to progression or reactivation of antecedent infections. MDS patients who are neutropenic at the time of transplant have an increased risk of infection and mortality. So there are numerous other factors that may contribute to progression of pre-existing infection, and these include defects of the innate immune system, age of the patient, organ dysfunction, prior antibiotic exposure. So important is that the presence of infection immediately preceding an allo transplant also impacts infections risk during the post-transplant period. And where possible, active infections should be treated before proceeding to transplant. So moving on to infections, I'm sure many of you have seen this diagram before, but it really shows well what one will have to look out for in the post-transplant period. So very early on, patients are at highest risk for bacterial infections because the patients obviously got neutropenia. Most patients will have a central venous catheter, which is a source for infection, and if not handled properly, CAPSIs can develop. And CAPSIs are catheter-associated blood infection. Patients may develop mucositis, acute graft-versus-host disease. So oftentimes, these patients have to be treated aggressively if a bacterial infection is suspected. And in the later on, the viral infections become more prominent post-engraftment, and it can once a patient has engrafted, patients should be monitored for CMV reactivation, and then as well as fungal infections can also become a problem. So why should we be monitoring these patients carefully? Because these infections need to be picked up early, and the appropriate antibacterial, antiviral, antifungal agent should be commenced as soon as possible. And so previously, the pre-engraftment period is considered, infections could occur between days 0 to 30 as illustrated in the diagram. And this is the critical point where you need to ensure that the patient is properly managed for whatever infection that has ensued. And all of this is dependent on when the cells start to actually recover. So fortunately, neutrophils and phagocytes tend to recover quicker than the B cells and T cells, and hence the viral infections tend to be the problem in the post-transplant period. This brings us to cytomegalovirus. So this is one of the most important pathogens complicating the post-transplant recovery period. Approximately 50% of the US population is latently infected with CMV, with a higher prevalence in developing nations. And prior to the widespread use of anti-CMV prophylaxis, approximately 80% of seropositive allo transplant recipients developed CMV reactivation, usually in the first 3 months. However, despite the prophylaxis, the incidence of CMV reactivation ranges between 20 to 50%, with episodes increasingly occurring after prophylaxis is finished, and this is late CMV. Approximately 16 to 18% of allo recipients with CMV reactivation develop disease. So what are some of the risk factors that can cause CMV reactivation? The most important risk factor is the serostatus of the recipient and donor, and it's been found that CMV-infected patients receiving a graft from CMV-naive donors are considered the highest risk. Other factors to consider would be total body irradiation that may be used for conditioning, the development of acute and chronic graft versus host disease, the T-cell depleting therapies that are being used, steroids, which are used at 1 milligram per kilo per day, doses more than 1 milligram per kilo per day. And obviously, we've mentioned the use of mismatched and unrelated donors can be can be a risk factor. So what are some of the clinical manifestations? So patients may develop interstitial pneumonia, enteritis, hepatitis, retinitis, encephalitis, and a CMV syndrome that includes cytopenia and fevers. And CMV-related mortality on average is 40 to 50%, and as high as 86% in severe pneumonia. CMV also has direct end organ effects and is also associated with increased bacterial, fungal, and other viral infections. So the diagnosis of CMV disease can be challenging, and as it may present with varying non-specific presentations. So PCR analysis remains the mainstay of diagnosis. There's no absolute cutoff to distinguish between infection and disease, but some authors suggest that using 10,000 copies per mole. However, in our center, we actually monitor the CMV viral load on once the patient's engrafted, and we use that as an indicator of CMV reactivation. So I guess it's dependent on center to center and how it is done. So once a patient has CMV reactivation, first line of therapy is intravenous ganciclovir. However, oral valganciclovir is frequently being used now. However, there is an increased risk of toxicity and marrow suppression, and hence it may be a problem being used as a standard approach in for patients. So the use of valganciclovir is something that will be dependent on a person treating the patient. Second line agents which are not available in states are foscarnet and cidofovir. However, these are reserved for treatment failure to ganciclovir, and are especially cidofovir and foscarnet can have toxicities as well. So it is recommended once you've commenced treatment for CMV, is actually to monitor the CMV DNA, and once it's no longer detectable, and we in our center use when we have two successive negative PCR negative, then we actually start tapering the dose of the ganciclovir or valganciclovir, depending what we are using. So other things that could be used are CMV immunoglobulins, and usually these are reserved for severe cases, especially where there's pneumonia or there's a lack of response to antiviral therapy. And some recent studies have suggested that CMV-specific T-cell administration can be effective. So a little bit on acute graft versus host disease. So histocompatibility differences between the donor and the recipient is the basis of obviously graft versus host disease, where activated donor T cells attack the tissues of the transplant recipient after recognizing the host tissues as antigenically foreign. So this results in inflammatory cytokines being released, which can cause tissue damage. And these commonly involve organs like the liver, skin, mucosa, and the gastrointestinal tract. By classical definition, acute graft versus host disease appears before day 100 post-transplant, whereas chronic graft versus host disease occurs after day 100. However, acute GVHD may still occur later than 100 days, or there may be an overlap syndrome where there are features of both acute and chronic graft versus host disease being present. So obviously, it's a balance between the graft versus host disease and the graft versus leukemia effect, and we use immunosuppressive agents in order to try and balance this. And these immune suppressive agents themselves cause problems. So I think Linda will be talking about some of the complications of immunosuppressive agents that we use, but some of the commonly used ones are the calcineurin inhibitors, methotrexate, MMF, ATG, and alemtuzumab or Campat. So I'm not going to go into a lot of detail into the actual pathophysiology of graft versus host disease, but there are basically three sequential phases which occur. So it's primary, priming, induction, and effector phases. So following prophylactic treatment and conditioning, there's a disruption in the integrity of the epithelium, and this leads to the release of damage-associated molecular patterns and pathogen-associated molecular patterns. And these molecules result in the activation of haemopoietic and non-haemopoietic antigen-presenting cells. Subsequent interactions lead to the activation, differentiation, and proliferation of T cells. And the different subset of T cells then play various roles in the pathogenesis of acute graft versus host disease. For example, T helper 1 and T helper 2 and cytotoxic T cells interact with target organs to promote damage. So in the intestines, intestinal stem cells are notably changed, impairing tissue regeneration capabilities, contributing to the forward feedback cascade of acute graft versus host disease. Here, the role of epigenetic regulators in the development of graft versus host disease has been thought to be possible, used as possible therapeutic interventions. So things like histone deacetylases, interleukins, etc. So as I said, I'm not going to go into a lot of detail here due to the time constraints. But this picture shows the same thing. And what it shows here is that the organs that are commonly involved in acute graft versus host disease are the skin, gastrointestinal tract, liver, and obviously the haemopoietic system. So what are some of the features? Patients may experience secretory diarrhea, hepatitis, skin rash, may develop oral mucosal involvement, and there's a grading system, which I will show you now. And patients with grades 3 and 4 have an increased risk of mortality. So there are several grading systems for grading acute GVHD. And the two most popular ones are the Glucksberg grading system and the International Bone Marrow Registry grading system. And the severity of acute graft versus host disease is determined by the assessment of the degree of involvement of the skin, liver, and the GIT. And the stages of individual organ involvement are combined with Glucksberg or without patient's performance status to produce the overall grade, which has prognostic significance. So as you can see here, the skin, liver, and gut are given a stage 1 to 4, and it actually describes the extent of the rash that may develop, whether there's erythroderma or whether there's desquamation or bullous formation. With the liver, monitoring the bilirubin and the AST, and then with the gut, it's monitoring patients' a volume of diarrhea that will, and associated abdominal pain with or without ileus. So if you have some time, you can look at the grading systems. So these are just some pictures to show what GVHD of the skin looks like. Here we could see there's macules on the palm. Here there's widespread erythema, desquamation, inflammation on this patient's back. Here there's some small erythematous lesions and papules. And this here is severe widespread erythema, desquamation, and hyperpigmentation. So these are some of the signs to look up. I guess you wouldn't want it to get this severe. So the management of acute graft versus host disease remains, the backbone of therapy remains corticosteroids, and the intense immunosuppression associated with the condition itself and enhanced by its treatment combined with disruptive barrier defenses, especially in intestine, place patients at the great risk of infection. So trying to balance the immunosuppression once the GVHD becomes a problem, and at the same time, CMV reactivation is common in this period along once graft versus host disease sets in, along with other bacterial, viral, and fungal infections. So obviously on your daily ward rounds on a patient that has been transplanted, you're required to actually assess with the different organ systems, and oftentimes you would pick up mucositis, and well, most of the time it may just be a mucositis that may be due to the cytotoxic agents that have been used. However, one has to look out for signs of GVHD in the mucosa, and this usually develops 2 to 4 weeks post-transplant. However, patients require, should have good oral hygiene, and if possible, prior to transplant, whatever dental work needs to be done should be done. Mucositis actually can become quite severe and may require total parenteral nutrition as well. So mucositis can be quite debilitating for patients post-transplant. With regards to other gastrointestinal complications, which I'm not really going to go into detail, but also just to watch out for this on your patients, you know, if they're vomiting, diarrhea, dry mouth, nausea. If these persist, may need investigation, stool MCS, endoscopies may be needed later on to determine if there's graft versus host disease happening in GIT. So also to watch out here, patients may develop cardiovascular complications, and this may be due to prior therapy that the patients may have received, for example, anthracyclines, or the actual patient having underlying comorbidities. So often to watch out for cardiovascular complications post-transplant, and again, renal complications. So renal complications may be associated with the use of TBI or conditioning regimens, and also the drugs and the immunosuppressive agents, the antibacterials or the antibiotics or antivirals that might be used may also contribute to renal dysfunction, and hence these patients should be monitored carefully when and with regards to neurological complications, patients may develop complications due to the drugs that may be used. For example, busulfan, phenytoin, if you're using those combinations, can give you neurological complications, and a host of other neurological complications which can occur. Pulmonary complications are one of the most common infections that you might pick up. So the patients may develop bacterial pneumonias, which are easier to treat when compared to the viral pneumonias, which can actually be become quite a problem. Hence, it's important to, as I said at the outset, to pick up these infections or signs of infection early and treat. Linda will be covering sinusoidal obstruction syndromes in her talk, but just to remember, drugs that you may use can affect the liver, and these include the drugs like busulfan, TBI can affect it, infections, iron overload, and it's important to actually monitor the liver function regularly in the post-transplant period. So the last condition that I'm going to talk about is hemorrhagic cystitis, which we currently have a patient in our ward, and it is quite traumatizing for the patient and us. So hemorrhagic cystitis is a serious complication of transplant, and the cystitis, obviously, it's the signs the patient might have is dysuria, urge frequency, low abdominal pain. The hematuria, when it occurs, must be graded. So it can be graded from grade 1 to 4, depending on whether it's macroscopic. For example, macroscopic hematuria will be 2, macroscopic with clots, and then grade 4 will be macroscopic hematuria with renal dysfunction. So what are some of the causes of hemorrhagic cystitis? So in the early pre-engraftment period, if a patient has hemorrhagic cystitis, it is usually due to the chemotherapy that may have been used. So drugs like cyclophosphamide, ifosfamide, and busulfan, these are the drugs can actually cause hemorrhagic cystitis. And so basically, it's acrolein that is a metabolite of these drugs that can irritate the bladder wall, causing bleeding. And however, in the late post-engraftment period, usually after day 14 or 15, hemorrhagic cystitis is usually due to viral infections, so BK virus and adenovirus, and sometimes CMV can cause it. And these usually are due to the immunosuppressive agents that are used, and can be quite problematic to treat. So the management of hemorrhagic cystitis, basically when you're conditioning the patient to ensure that proper preventative strategies are used. So patients should be properly hydrated. The Mesna should be used at adequate doses. And so usually, if these patients are properly treated at the time of conditioning, the complications can be reduced. However, when there's viral reactivation post engraftment, these can become a bit of a problem. So here, treatment usually is conservative, and patients have to be adequately hydrated. Patients experience pain and need adequate analgesia. The patients need platelet support. Coagulation studies also need to be regularly checked, and usually 3-way bladder irrigation is used, and antispasmodic agents. Unfortunately, drugs which have been shown to have some sort of effect, which with various authors having different experiences, but things like cidofovir, which is associated with certain toxicities, and then leflunomide can be used. We do not have access to this. And when the bleeding, when you experience from stage 2 to 4, then you may require the urologist to help, and agents being used are things like alum, formalin, and so this is where we are with our patient currently. So tomorrow she's going to have alum inserted via 3-way catheter. So my last slide, I decided to speak a little bit on graft failure, because that is also a problem, and it may occur in approximately 5%. It's not common, but it's obviously driven by the immune system, and it's dependent on things like infection, recurrence of the disease, etc. So I won't go into too much detail because we're running out of time. So I will end here, and these are some of the references that I used. And my last slide is a little bit of a milestone for us. On the 1st of September, we performed our 100th transplant. And we just wanted to say thank you to a whole lot of people that actually got us here, including JP Singh, Natasha Supasad, the Sanbus team, and a lot of our other colleagues that have phoned for help, Dave Britton. And so, yeah, this is our little milestone, and these are all the people that were involved in our transplant last week. So I will end here and introduce, sorry, let me just stop sharing. Check if there's any questions before I go on.
Charlene, I just think we should congratulate you. 100 transplants, that's a huge milestone. Well done, and to you and your team. Absolutely fantastic news. And yeah, I also hope you get the chance to publish the results or help or work with the teams around the country that's currently looking at this. This is really an amazing achievement. Fantastic. Well done.
Thank you, Juan. And I did chat with Estelle, and we're hoping to join the registry and add our data on. So I have a few questions in the chat group. What is CMV viral load cutoff generally used for preemptive therapy? So for, I think this is what we do in our unit, but by no means the most experienced transplanter. But once we find that we have two successive increases, so it goes up to like 500 and on an upward trend, then we actually institute the ganciclovir. I don't know what everybody else does. Perhaps you can ask Andrew. Andrew's on the call.
Sorry, I hope you don't mind me butting in. Sorry. Yeah. So I mean, we tended to use 1,000 because we obviously have got issues about getting authorization. So what I tend to do is you see something approaching 1,000, then you put in a request for valganciclovir, so the oral, and you're going to see them a week later. If the next week they've dropped, well, all well and good. If they're still sitting around there, we tend to start the valgan, and if they've jumped dramatically, then we admit for IVE ganciclovir. So it's a kinetics as well as the absolute count. So if you see someone one week they've got 1,000 and the next week they've got 15,000, I mean that's red flags. Then I tend to say admit, start treatment straight away with intravenous, making sure drugs in. I mean, just the one thing about CMV viral loads is you can sometimes miss gut reactivation. So a CMV colitis can not have very much in terms of blood reactivation. So some of the labs have got the ability to do CMV PCRs on stool. I mean, AMPAT specifically is doing it for us. So that's always a useful marker in someone who's got diarrhea post-allogeneic transplant, and you're trying to just get a handle on, while you're waiting for the colonoscopy to be arranged, etc., is this kind of more GVH or metabolic, or is it CMV? And they just in terms of drugs, there are new prophylactic drugs coming onto the market. Letemavir is coming, so that's useful. And I know I had some approaches about maribavir, but I don't think it's going to be a huge market for us here, but I mean, it is a drug that you might be able to get on a Section 21 if you fail, because cidofovir and foscarnet all have their own toxicities as well and are expensive. They're not cheap.
Okay.
Thanks, Andrew. I see Cecile has got a hand up as well.
Hello, I hope everybody can hear me. Yeah, I just want to agree with Andrew. We also use log 3 or 1,000 copy numbers or patient approaching it. And again, also look at the kinetics. If there's a rapid increase, then we tend to admit. We're fortunate that we don't have to motivate. We can admit and start the Ivigan cyclovir immediately, but beds are sometimes our issue, and we may also have to start oral Valgan till we can admit the patient. But the log 3 or 1,000 copy numbers is also our cutoff.
Okay, thank you, Cecile. I think there was so Andrew says, struggle with GBH degrading. Skin is easy, but GI and liver are difficult. And the scoring system is mostly so I agree. I don't think many of us use the skin is the easiest way, the only system that you can actually grade properly. Interesting. Okay, Andrew mentioned the stool PCR. Yeah, and there's another thing. Autologous. There's sorry, this is the question autologous. So we also don't monitor this. This is done only for allo patients, and CMV is not. We do not monitor our auto patients for it unless we suspect that something might be going on, that maybe the liver functions becoming abnormal, but it's not something we do routinely on our auto patients. Sorry, there's somebody wanting to say something.
Yeah, so it was me again. Sorry, I'm butting in again.
Yeah.
Just but hemorrhagic cystitis. I mean, BK and adenovirus are the dirty little secrets of haploidentical transplants. I mean, if it's not one, it's the other, and you can really struggle. And there's no great treatment except having a good urologist at hand.
Yeah, thanks, Andrew. We realized that we've been struggling with our girl for 3 weeks now. So anyway, thank you, everyone. I'm going to introduce Lindo. So Dr. Lindo Kushler-Gokwana. She is completed her undergraduate studies at Wits University and qualified as a specialist physician. After completing a training in MED at Wits as well. She was the recipient of the Asher Dove Medal for performance in the FCP Part 2, and she's currently a clinical hematology fellow at Chris Hani Baragwanath Academic Hospital. And I had the pleasure of meeting her at SASH, and she's a wonderful, very pretty lady. And over to you, Lindo.
Thank you, Dr. Paratnath. That was quite a nice introduction. Thank you to the deep dive team and Prof. Verberg for organizing the deep dives. It's actually quite a pleasure to watch them and listen to them, because we learn so much from them. I'd also like to thank Dr. Paratnath and also congratulate you on 100 transplants. That is a huge feat for us people that are, quite young in this field. That seems like massive to us. But I'm going to go straight into it, so that in the interest of time. So today I'll be speaking about hematopoietic stem cell transplantation complications of endothelial origin. Are my slides moving? They don't seem to be moving. Okay, they're moving now. Okay, this is just a brief outline of my talk. And I'm going to delve straight into it by defining them as a group of complications that occur early after transplant. This is usually within 100 days. And they share common characteristics, including that they begin at the capillary level, they have overlapping signs and symptoms, and they result in multi-organ dysfunction if untreated, and this may be irreversible. So the endothelial cell state results in a fine balance of inflammatory and anti-inflammatory factors, and this results in an equilibrium. Disruption of this balance will result in endothelial activation. If the insult is prolonged, this will result in endothelial dysfunction. So risk factors for the pathogenesis of endothelial related complications is based on the risk factors, which include both intrinsic risk factors and transplant-related factors. These, if there's repeated endothelial activation, as you can see here, or prolonged endothelial activation, this will then result in endothelial dysfunction and will result in the syndromes that I'm about to speak about, including TATMA, capillary leak syndrome, and Grafman syndromes. This is another schematic diagram showing that these insults will start with just endothelial activation, damage, and then eventually that will result in endothelial dysfunction. So this is a list of the early complications of endothelial origin. And I've put sinusoidal obstructive syndrome in red. And this is because its pathogenesis is thought to not solely be endothelial in nature, and it's often not included, depending on what text you're going to read. But I thought it was quite important to include it, and also Dr. Parasnath didn't cover it, so I will be speaking about it. And I won't go in depth into every single topic because in the interest of time, I do have very limited time. So I'm going to start with sinusoidal obstructive syndrome, which I'm going to deem SOS. This was previously known as veno-occlusive disease of the liver. It's seen in children quite often, and it's characterized by jaundice, fluid retention, a tender hepatomegaly occurring between 35 to 40 days after hematopoietic stem cell transplant. There are a number of risk factors, but I think notable ones are the presence of previous liver disease, the type of conditioning regimen that's been used, with myeloablative conditioning regimens being more giving you a higher risk. Older patients, female gender, the use of gemtuzumab ozogamycin or inotuzumab ozogamycin, and concomitant use of progestogens or azoles such as posaconazole or voriconazole. This is adapted from the EBMT, and these are the risk factors, and I've mentioned some, including older age, the use of gemtuzumab, and some transplant-related ones where myeloablative conditioning regimens, the use of busulfan giving you higher risk of SOS. So hepatic metabolism of certain drugs such as cyclophosphamide by the cytochrome P450 system often produce several toxic metabolites. We just spoke about acrolein now, and these metabolites are ordinarily converted into stable non-toxic metabolites by the glutathione enzymatic system and then eventually eliminated. But what happens is that if glutathione is often consumed by busulfan, BCNU, or even radiation. And these toxic metabolites are then not metabolized, and they cause damage to the hepatocytes and the sinusoidal endothelium. This causes loss of fenestrine in sinusoidal endothelial cells, and then the red cells then penetrate the space of disc, dissecting out the sinusoidal lining, space of disc being over there. This dissected endothelium then embolizes, causing sinusoidal obstruction. This then results in hepatic venous outflow obstruction and post-sinusoidal hypertension. So the clinical manifestations of SOS, as we've mentioned, are weight gain, painful hepatomegaly, and consumption of transfused platelets, and this should not be due to refractoriness or platelet refractoriness. There may be features of multi-organ dysfunction, which include pleural effusions, pulmonary infiltrates, renal, cardiac, and pulmonary failure, and neurological symptoms. So in investigating SOS, we'd go down the route of using imaging, using ultrasound Doppler. This would tell us more about hepatomegaly and splenomegaly, the presence of ascites, gallbladder wall thickening, and the reversal of the portal venous outflow. Portal venous flow, but this is a late sign of SOS and may not be there if you've caught it early. There's also research or studies that have been done to consider composite biomarkers, and best if they're done at day 0, but I'll speak about these a bit later. You may also do transjugular hemodynamic studies, which may measure hepatic venous gradients safely without being invasive, and they're highly specific but moderately sensitive. Transvenous liver biopsy is more invasive and maybe false negative because of the patchy nature of the disease. But if you need a diagnosis and the diagnosis is crucial, it can be done. The diagnostic criteria includes, there's the Baltimore and the Seattle criteria. I'm going to show you the Seattle criteria in a moment, where there's criteria for adults and for children, where in adults, we look at the presence of whether this is occurring within 21 days of transplant or later than 21 days post-transplant, where the Seattle looks at a bilirubin that's greater than 2 milligrams per deciliter within 21 days of stem cell transplant. Otherwise, the Seattle looks at an unexplained occurrence of more than 2 of the following findings within 20 days of stem cell transplant. The severity grading is of importance because this also guides management of SOS, where any patient with multi-organ dysfunction is considered to be severe, but the grading system is dependent on the time since the first onset of symptoms, the level of the bilirubin, the doubling time of the bilirubin, transaminases, the degree of weight gain, and the degree of renal dysfunction. Management is dependent on whether it's mild to moderate, whether the disease is mild to moderate, and there are supportive and specific measures, where supportive measures include maintaining euvolemia, minimizing hepatotoxic agents, and paracentesis if it is needed. Specific therapy is considered in patients with mild to moderate disease if the supportive measures are not, there's no improvement with supportive measures. Supportive measures include the use of defibrotide. I'm going to speak about defibrotide more in depth at a later stage. Methylprednisone and TIPS procedures. Then I'm going to move on quickly to transplant-associated thrombotic microangiopathies. This is a triad of hemolytic anemia, thrombocytopenia, and organ failure. It has a high mortality. The incidence varies because there isn't a standardized established definition for TA-TMA. The risk factors include conditioning regimens, TBI, infections, and immunosuppressive therapy. Typical presentation is often multisystemic, and unlike the other TMAs, or particularly TTP, it's associated with a normal Adams TS13 activity. There are a number of diagnostic criteria, and they're based on red cell fragmentation, anemia, a raised LDH, low haptoglobin, and thrombocytopenia. This is where they would fall under causes of TMAs. And what's important is that the pathogenesis is actually thought to be a 2-tiered or a 2-hit pathogenesis, with the first hit, as you can see over here, being early in transplant, while the patient is still aplastic, and it's caused by the conditioning regimen. And the risk factors include prolonged immobilization, the use of busulfan, and severe infections. And then a second hit occurring over here would be where there's further endothelial injury, probably caused by calcineurin inhibitors, especially in the setting of GVHD or severe infections. This, unlike the other endothelial syndromes, involves the complement cascade, and its management thus includes complement inhibition. There's also evidence that there's neutrophil extracellular traps that are thought to appear quite early in the disease and could actually be possibly be used as a biomarker to diagnose it earlier. As I mentioned, there's a number of diagnostic criteria that exist, and that's why there isn't a unifying diagnosis for TA-TMA. And this is adapted from the bone marrow transplant in 2021, where they tabulated all the different diagnostic criteria, where what seems to be overlapping between these criteria is the presence of schistocytes, the LDH, the thrombocytopenia, the presence of anemia. And what seems to be also important is the presence of proteinuria. But the EBMT, I'll speak about this later, the EBMT looks at proteinuria as whether you should use advanced therapy or just supportive therapy. This is a table, I thought this was quite nice, where it looked at the risk factors for TA-TMA, and it looked at patient-specific, transplant-related, conditioning regimen risk factors, and infection risk factors. So when screening or considering a diagnosis of TA-TMA, the EBMT suggests that an LDH should be done 3 times a week. Patient dipsticks should be done 3 times a week, and blood pressures daily. If there's any data or any problem over there, then you would move on to assess for the presence of schistocytes, and you do quantitative assessment for proteinuria, and you'd measure the level of haptoglobin level and complement levels. If the patient does not have proteinuria or doesn't have an increase in their complement, you can just simply stop the calcium urine inhibitor and treat any possible triggering cause, such as infections of GVHD, which I mentioned earlier. But if the patient does have proteinuria and increase in complement, then more specific therapy is probably needed in the form of therapeutic plasma exchange, rituximab, defibrotide comes up again, and complement inhibitors. I'll speak about these drugs in more in depth when I finish all the syndromes. So then I'm going to quickly move on to capillary leak syndrome, which is an episodic crisis of hypotension or hyperperfusion, hypoalbuminemia, and severe generalized edema. Its manifestations can be reversed with vasopressors, fluids, and colloids, with volume expansion, really. It's described after administration of IL-2, IL-4, TNF-alpha, GCSF, and hematopoietic stem cell transplant. It's thought to be due to endothelial damage with high levels of vascular endothelial growth factor playing a role. Its diagnosis is based on unexplained weight gain of greater than 3% in 24 hours or a positive fluid balance despite the use of furosemide. Its management includes discontinuing the GCSF, steroid therapy, and the use of bevacizumab, which is an anti-VEGF. Engraftment syndrome and peri-engraftment syndrome was previously known or called or deemed autoaggressive syndrome or aseptic shock syndrome. It's basically the presence of a high and well-tolerated fever, which occurs when the first neutrophil count is detected on peripheral blood. It's due to cytokine release resulting in systemic endothelial damage, and it leads to local and systemic tissue injury. Its administration of GCSF is thought to contribute to its pathogenesis, and its risk factors include autologous stem cell transplant for diseases that are not intensively treated with chemotherapy, the intensity of the conditioning regimen, prior use of lenalidomide or bortezomib, and the use of GCSF. Prophylactically, if one is concerned that the patient may have high risk for engraftment syndrome, you can avoid the use of GCSF in high-risk patients, and treatment, you would have to stop the GCSF, and the thought is probably the use of steroids would assist. There are two, it's been described twice as far as the diagnostic criteria, first in 2001 by Spitzer, and then in 2003 by Mailino. The Spitzer criteria is a bit more difficult or more complex to make a diagnosis, where Mailino is more simpler, and it's basically a non-infectious fever and another major criteria or diarrhea since 24 hours before engraftment. And this is the criteria: the fever of greater than 38.3 degrees Celsius, erythroderma in greater than 25% of the body surface area, pulmonary edema, hypoxia, or a sudden increase in CRP values. Minor criteria include weight gain, an increase in your creatinine, hepatic dysfunction, diarrhea, and encephalopathy. Idiopathic pneumonia syndrome is characterized by signs and symptoms of pneumonia and widespread alveolar injury. Infection, cardiac dysfunction, acute renal failure, and iatrogenic fluid overload must be excluded prior to making this diagnosis. It has a high mortality. Its median onset is within 19 days of transplant. Its risk factors include high intensity conditioning regimens, concomitant acute GVHD, older recipient age, malignancy other than leukemia, and the use of methotrexate and busulfan. Diagnostic criteria include signs and symptoms of pneumonia, multilobar chest radiograph infiltrates, abnormal pulmonary function tests, and the absence of an infectious organism that's cultured on bronchoalveolar lavage specimens. Pathologically, on biopsy, they often show diffuse alveolar damage with hyaline membranes, bronchiolar inflammation, and lymphocyte infiltration. It's thought that diffuse alveolar hemorrhage and peri-engraftment alveolar syndrome is actually part of IPS, but in some texts, they actually describe diffuse alveolar hemorrhage on its own. So just briefly, before we finish, I just want to speak about, because I left the drugs till after, therapeutic interventions in endothelial dysfunction. So this I adapted from the EBMT course from last year, where this is a schematic diagram showing all the drugs that could actually be used, because the pathogenesis of these syndromes is actually quite similar, except for TATMA, which includes complement, where defibrotide can actually work for both TATMA and sinusoidal obstructive syndrome. There's been use of infliximab, rituximab, complement inhibition. Even statins have been described in treatment of endothelial syndromes and transplants. This is a schematic diagram of the complement pathway, with narsoplimab being the most recent drug, not yet FDA approved, that can be used in TATMA, and eculizumab and ravulizumab being able to work against these syndromes. So defibrotide is indicated in severe forms of SOS and has been used also in TATMA prophylaxis and GVHD prophylaxis with good results. Very severe forms of SOS, though, will have poor outcomes even if despite the use of defibrotide. It has profibrinolytic, anti-inflammatory, anti-thrombotic actions, and it achieves this by multiple actions. And in this table, I've actually shown the different actions where it decreases P-selectin expression, it decreases NF-kappa beta activation in the bone marrow, and by doing this, it has the effects that I've mentioned. So its mechanism is not fully understood because it has so many, and it's thought to restore endothelial integrity. It's given at a dose of 6.25 milligrams per kg, 6 hourly for 14 to 21 days, and it should be discontinued 2 hours before an invasive procedure. It has no antidote. Its half-life is about 2 hours. Its adverse effects include nausea, vomiting, hypotension, epistaxis, and hypersensitivity. There's no actual other pharmaceutical agent that has been proven to have efficacy against veno-occlusive disease or sinusoidal obstructive disease. Eculizumab, we are familiar, even though we don't use it as often, but we don't use it at all instead because of its expense, but we are familiar with it in its use with TATMAs, PNH, atypical HUS, NMD, NMO spectrum diseases, and myasthenia gravis. So it's a terminal complement inhibitor. It's a humanized monoclonal antibody, and it binds with high affinity to the human C5 complement protein and blocks the generation of pro-inflammatory C5a and C5b all the way down to 9. The dosing for TATMA of eculizumab is based on or adapted from atypical HUS dosing with an induction of 900 milligrams weekly for 4 doses, maintenance, and then taper. Its adverse events are infusion reactions and encapsulated bacterial infections. Narsoplimab, I mentioned earlier as well. This is a bit of a newish drug that's not yet FDA approved. It's a novel selective complement inhibitor that's thought to block complement activation and endothelial injury without the immunological dysfunction observed with broad complement inhibition. It targets the mannan-binding lectin-associated serine protease MASP2, and its serious adverse effects that were seen in the trial that was done for TATMA was GVHD, neutropenic sepsis, and acute renal failure. This is a table that actually shows the different complement inhibitors and their response rates in TATMA, where you can see eculizumab had a response rate of 67 to 78% in adults. Narsoplimab 61% in adults. And these are more novel agents that probably will be available or will be available soon. Other agents that are used or other interventions include anti-CD20 monoclonal antibodies such as rituximab, withdrawal of the calcineurin inhibitors, which is quite important, thrombomodulin, statin therapy, angiopoietin mimetics, and alpha-1 antitrypsin. I'm just going to briefly say something about the use of biomarkers for early detection of endothelial dysfunction. This is a field that's not really validated, but there are thoughts that if certain biomarkers can be measured earlier on within the transplant period, then we could determine whether the patient is at higher risk of developing TATMA or any of the other endothelial syndromes. But the concern here is that the biomarkers are not yet validated. There's lack of consistency between different studies, and they also lack specificity because a lot of the biomarkers can be increased with infection or any other stressors. So I draw to my conclusion at this point, where this is a diverse group of conditions. They have a similar pathogenesis. They have life-threatening complications, and their diagnosis is often elusive because of their overlapping features. So multi-center studies are indeed needed to be able to look at these diseases better, and biomarkers may be of assistance in the future. I'd like to say thank you at this point, Ngozi kakhulu, and these are my references.
Thank you, Lindo. That was excellent summary of complicated problems that can arise, that we often struggle with. I just wanted to say a thank you. I see Dr. Nazipo Bengu and Andiswa Adondo on the call, and they're actually from Takeda and sponsored Lindo and I to attend this this workshop, which we both found very useful. And it was our promise to them that we would feed back what we learned at this workshop to everybody. So yeah, so thank you to Takeda for that. And once again, Lindo, thank you so much for doing an exceptional job with this difficult topic. There's a few comments that were made. Andrew mentioned that the transjugular, the tips may be a problem in the post-transplant period because of the thrombocytopenia.
Absolutely.
And he also mentioned that he's learned that GVHD can also occur in the kidney. And he spoke about chronic TMAs in 2 of his patients, which I'll allow him to talk about a bit. And then I think Jacques asked about the defibrotide and then in the country. And Andrew says that it is available in Section 21, but there's a lot of logistics around getting it. And alternatives for defibrotide, I think there aren't any, but perhaps when Andrew is chatting with us, he can tell us what they use, because we considered using Ursodex, or I forget the pharmaceutical name, but as a prophylaxis. I don't know whether that helps, but we don't actually use anything. Yeah, so I'll ask Andrew to unmute and just talk a little bit about his.
Yeah, okay, thanks, Charlene. So yeah, so some of the comments, yes, I mean, Garrick's asking about heparin. So yeah, we are actually still using heparin unless we're running into trouble. But yes, I know the trials didn't really show it, but we are definitely using ursodeoxycholic acid. But I mean, yes, I agree with Marcel. I mean, like, we haven't used defibrotide a lot in SOS, because really just logistics. By the time you've really actually confirmed the diagnosis, then trying to get someone to pay for the drug and then get it into the country, it's the patient is either better or dead. So it does kind of it does kind of preclude more widespread use. I mean, if it was more widely available and we could start it knowing we'd get it funded, it might be more reasonable to consider, but it really remains a pie in the sky. Just in terms of the TMAs, I mean, yes, we certainly are seeing, I think the classic acute TMA, transfusion-associated TMA is very easy to recognize. I mean, it's very much like a overlap between TTP and HUS, but I mean, the chronic ones we've just seen some hypertension in the clinic, and then proteinuria, and then the platelets have started becoming a problem. And as I said, we've had two, in fact, we've had 3 kidney biopsies, but the one was a bit more complex with immunological features as well. But we've had definitely 2 where the one was a lady was actually quite far out from transplant. So we've definitely was over a year when we started running into kidney issues, and it was really thought to be a GVHD variant. And the other young boy used to be a patient of Michael's who was an aplastic. We'd given obviously ATGAM and the cyclosporin too. Then he'd failed, and then he had a 9 out of 10 mismatched graft, and then obviously post-transplant cyclosporin, tacrolimus again, and then developed TMA, and we went from bad to worse. He had exchanges, rituximab. We don't obviously have eculizumab either, and yeah, unfortunately he didn't make it. So yes, it's a disease I think we are probably under-recognizing. You know, you see a bit of hypertension in the clinic, kidneys go a little bit off, and you just tend to stop the calcineurin inhibitor, and everything gets better. So there may be actually cases that we're not diagnosing, but we are actually managing.
Okay, thank you, Andrew. I guess, you know, what I realized, we're not as experienced as you are in transplant, but I think some really important aspects of just general work that we do in the ward every day, to understand that, you know, we have medical officers that may not be experienced in transplant, and even the specialists that work with you, that you're trying to train. It's a lot of learning on a daily basis, and I think it's really, really important to scrutinize patients' blood results and look for slight changes. For example, if the platelets are dropping and your patient's on a calcineurin inhibitor, get a smear, look for fragmentation. You know, you're monitoring your patient regularly, so these are just little things that might make a huge difference to pick up the complications early. And I think that for me has been what I've learned, is that, you know, you know all this information about what the complications are, but can you pick them up early and do something about it? So it's just something practical that I just wanted to say. And then with regards to heparin, we actually do use Clexane prophylactically on our patients that are getting regimens like BU, flu, and we stop it when the platelet count drops. Yeah, so just some little things that I think are important. And I think important is to actually upskill staff, upskilled in our unit, for instance, the nurses are not transplant trained, and to encourage them to report changes in the patients, you know, things that you might think are maybe insignificant, but could herald something really serious. I see Estelle has put up the link for CPD. And then Estelle says she asked SOPs. Estelle?
Hi, I'm trying these slides. I'm struggling, as everybody can see. I'll try to put on the link again. And people must tell me what they prefer, the link posted or the link like this. You know, we're experimenting a bit. Sorry, people.
Yeah. So I don't know if there's anyone else that wants to say anything. Cal, Cecile, your experiences, any pearls of wisdom to share with us? Because I guess there's a lot of people on the chat that actually aren't transplanters and gain something from your knowledge.
Let's hear what Cecile, if Cecile has something more to say. I don't know, she's got so much experience together with Andrew over the years.
Well, I don't think I have anything to add. I mean, this was an amazing session, and there were so many topics covered. It would be very difficult to try and add anything. As far as the VOD prophylaxis, we will always use the low-dose heparin. Ursodeoxycholic acid has now become available to us, and we'll add it to it. But we've had a very low incidence of VOD in any case, just with the low-dose heparin. It does seem to be lower in T-cell depleted allografts, but we also don't see much in our autografts, which is difficult to explain, except for the fact that the heparin might be working. So, yeah.
Thanks, Cecile. Oh, guys, the QR code works. So if you can scan the QR code, it actually works. So,
Ria, I will put it in the chat box because really, oh, you couldn't use the QR. Yeah. So that's the point. So we will put it in the chat box, and now we've tried.
So I think for next week, everybody needs to download the app, the QR code app on your phone. That's your homework for next week.
It's not a big deal. I'm very happy to post it. People, let me quickly retrieve it from my little hidey place. Yeah, so I mean, I'm going to hand over to Charlene and Vernon. If there's any more remarks, I'll go look for the link.
I just want to say once again, thank you for allowing me this opportunity to share a little of my thoughts, and thank you to Takeda for giving us the opportunity to attend the workshop last year, and thank you to Lindo for her wonderful presentation. And yeah, I learned a lot, and I guess we continue to learn. Every transplant, in my opinion, you're learning something new. No two transplant patients behave the same. And yeah, it's just learning on the job every day, learning from your mistakes, your omissions, I guess. Yeah, thank you, everyone.
And thank you to you, Dr. Parasnath, and congratulations on your 100 or your centenary.
Thank you, Lindo. I'll hand over to you, Vernon.
Great. Thank you very much, Charlene and Linda. I can see from the comments that people really enjoyed it and appreciated the effort you put in. I really thought it was a great approach. And I think you pitched it in the right way for an audience of both transplanters and non-transplanters. I just want to maybe make a general comment and say there's really a great need to expand transplant experience. And as we are transplanting more and more patients, more general hematologists, even if they don't transplant themselves, will be seeing and following up some of these patients afterwards. So we're definitely looking at creating space so that people who have not had the opportunity to have exposure or training in transplant to perhaps come and do a fellowship with us in the future. And it's something Estelle is also working on. So we are definitely between me, Estelle, and Cecile, we'll be seeing what we can put together to create such an opportunity for some exposure and time spent perhaps in our unit and maybe some of the other units like your, Charlene, or the one in one of the private ones perhaps want to do the same, because it's really valuable. And even if you're not necessarily, fully experienced to do transplants independently, I think the knowledge and seeing these things in real life is the best way. Like someone said today, the best way to get an MBA is to actually start a business yourself. And I think that's probably true. Transplant is really a hands-on endeavor that doesn't come from textbooks. So once again, great talks. Thank you very much. Thanks everybody for coming, for spending the time with us. Thank you, Estelle and team. Gardine, Elzaan, Melanie, everyone that part of the arrangements, people who kindly sponsor us. Charlene thanked Akira as well for their inputs. We really appreciate all of that, and we look forward to seeing all of you next week again. Thank you. Bye-bye.
Thank you. Bye, Vernon.
Bye, thank you.